I am Satarupa Dasgupta. I am an assistant professor of applied communication at Ramapo College of New Jersey. So my research is primarily on health communication, program development and evaluation, and I have working experience in both academia and not-for-profit sector. So I have worked on sexually transmitted infection intervention development among high-risk populations like commercial sex workers. I've also worked on sex trafficking prevention and rehabilitation of sex trafficking victims in international settings. And I also work in intimate partner violence prevention and support services program development for immigrant populations in US. In addition to being an academic, I have also been a voluntary sexual assault and domestic violence advocate in my state of residence. And I have been affiliated with culture-specific organizations, basically organizations that offer support services to immigrants, especially immigrants who have been victims of violence. Like when we talk about community health is ultimately a very important subsection of public health, which includes like initiatives that can help community members to maintain and improve their health, to prevent the spread of infectious diseases and prepare for natural disasters like this pandemic, COVID-19. I would also say that community health is very intersectional, because ultimately it is the intersection of healthcare, it is the intersection of economics, it's the intersection of social interaction of community members. And if you look at it, intersectionality is a theoretical framework that posits that multiple social categories like race, ethnicity, gender, sexual orientation, socioeconomic status, they ultimately create interlocking systems of privilege, of oppression that can work at the macro level, at the social structural level. And so public health, community health, it has a commitment to social justice. And I think it makes a natural fit with intersectionality, especially with this focus on historically marginalized populations. Like how can community health workers, they can contribute to better health inequity? I'm speaking from my experience of working with vulnerable populations, at-risk populations. I think primarily through community health that focuses on the participation of the community members. So that involves the researchers like me, and community members and equitable partners in addressing the health disparities. So we need to create a participatory space where everybody's voices get heard, where the participatory space where there is a generation of a community voice. And also collaborative partnerships among multiple sectors, multi-sector collaborative partnerships. So this has to be like a prominent strategy for community health improvement, because collaborative partnerships, it can bring about a community and systems change, like in the environmental changes, community-wide behavior change, and even like more distal population level behavior change. This is something I think is very important for addressing health equity. Also, a culture-centered approach, like it's something that Mohan Datta came up with. So culture-centered approach, where he examined the expression of community voices and the articulation of community agency and voice, and focus on the role of community partners. This can result in community-centered outcomes of the partnership. So this can address the health inequalities by building communication infrastructure, by listening to the voices of the people who are traditionally voiceless, who have been traditionally the subaltern communities, who have been erased from discursive community spaces. And lastly, I would say a focus on interdisciplinarity, a focus on intersectionality, because we have to assess how multiple forms of interpersonal discrimination, it can shape the health of marginalized groups. And so we have to focus on more like creative, qualitative, multidisciplinary, and community-based research that focuses on participation in order to incorporate the core idea of intersectionality, including social inequality, complexities of relationality, like power, social context, social justice, and we have to incorporate it into social health research programs, so community health programs. So as I said, like participation, focus on participation, creation of space where there are voices of all the community members, a collaboration between multiple sectors, researchers, social workers, advocates, health workers, community members, then a focus on culture-centered approach, where there is a focus on culture-centered, community-centered outcomes of any partnership or project. And lastly, a focus on intersectionality and interdisciplinarity. These are the things that I think will work. Like I would like to speak within the context of my latest research, where we had worked on community-based harm reduction strategies among commercial sex workers. So I had collaborated with a colleague in social work, and we combined our field-based ethnographic research between 2009 to 2018 on best practices, community-based best practices among brothel-based and non-brothel-based sex workers in India. And what we found out is there are harm reduction strategies that are primarily community driven, like multiple strategies like peer outreach communication, some peer outreach communication that is spearheaded by the sex workers themselves, negotiation with key stakeholders within the sex work industry like police, pimps, even criminals, neighbors, stakeholder and NGO negotiations, non-government agencies who are not exactly running the program, but there's still a negotiation with them. Formation of self-regulatory boards that are formed by the sex workers themselves to regulate the industry, to prevent sex trafficking, to prevent the entry of underage women in sex work. And partnership with the police, partnership with NGOs, and drop-in centers, which can provide relief for the sex workers themselves. All of these are community-based projects, and all of these, they work in harm reduction in the sex work industry, and they create participation, they create leadership, they create resistance. So, and they allow the sex workers to engage with hierarchical and exploitative social structures that are already in place and within which they're situated. But, like, I'll just like make a small comment, like institutional inequalities are not something that can be dissipated easily, because I found that even in community-based responses, there are conditions of marginality that will get replicated even within participatory processes. So it's not like if we move on to community-based harm reduction strategies, then we are going to get rid of those conditions that create marginality. It's not that easy, but then there are small developments, that small improvements that happen that make a huge change in the lives of the sex workers. Facilitators, like I have been like talking about it, I think intersectionality is extremely important to understand the historically oppressed populations, why they have been marginalized. Then interdisciplinarity, we need collaborative partnerships with people, with organizations from multiple sectors. We need to focus on community participation, create a participatory space to generate a community voice. And then finally, cultural competency is extremely important, cultural appropriateness, maybe sometimes linguistic appropriateness. Regarding barriers are multiple, they're complex, and in most cases they're co-occurring. I can speak from within the context of my own research, like I work with sex workers, transgender populations, IPV victims. In many cases, they're like structural barriers, like poverty, there's violence, there's stigma, because poverty, violence, and stigma, they sometimes interconnect with each other, and they create institutional inequalities within the healthcare system. Sometimes discriminatory attitudes among the healthcare providers themselves, and sometimes there is a dearth of culturally competent healthcare providers who have experience and sensitization in the issues that the victims are facing. So this is like a whole gamut, but like there are barriers, like there are facilitators, there are barriers for community-based health projects. So for COVID-19, I had looked at the impact of COVID-19 on healthcare seeking behavior among transgender community in India. And what we found out is like, it's disastrous. The transgender community in India have always been hyper marginalized. They've been stigmatized. And healthcare has always followed a neoliberal ideology in India. And the neoliberal ideology positions marginalized communities like transgender communities as voiceless entities, completely reinforcing the structural inequalities in place. So what we found out is like due to COVID-19, the testing service like COVID-19 testing services, or even HIV STI screening services, gender transition services, mental health support services, everything has just ceased to exist, and there are no responses, no reactions from the government regarding that, and there are no voices from the transgender people in the Indian media. So basically what I feel is like there has to be an involvement of the transgender individuals themselves in healthcare decision making in the discursive space of India, and we need more community-based interventions in the post-COVID-19 scenario, because if we have to address the structural challenges to health and well-being, this is what we need: community-based projects. I would say, like, I think for most community health-based projects, there has to be a focus on the paradigm of participation and development to get the voices of the disenfranchised heard. Next, we have to focus on cultural competence. We have to conduct education and training in community health workers in cultural competence, because they can support community health workers' effective integration into, say, primary healthcare clinics that are seeking to reduce health disparities and provide better health outcomes for underserved communities. And ultimately, like I have been like talking about it a lot, there has to be a focus on intersectionality, because it's an intersectional lens that can provide a critical praxis for understanding the distribution of risk, infection risk, health outcomes. Let's say if we are trying to analyze a health burden of a pandemic of COVID-19, we have to have an intersectional lens. And intersectionality can also provide an analytical tool to propagate a appropriate response to the pandemic that we have.